Our next speaker is Dr. Shervin Shadianloo. We're very fortunate to have him as part of our team because he's one of those very few individuals who are board certified in both child and adult psychiatry. So Shervin, please come over.
Thank you very much. Can we just take my face cover up? Okay, hello everybody. Hope you're having a good day. Thank you, Lynette, for introducing me. I'm a child psychiatrist and I work in two different clinics at Northwell, both of them primarily focus on working with transgender individuals, one in Long Island and also in Friedman Center in the city. I'm usually doing a consult job there. Can we start the slides as well? Thank you. Next one, please. I thought like just briefly mention that are things that I might want to talk about. Three subjects I was thinking. One is that what are the special needs of transgender people in terms of their mental health care? There are some differences in the general population. I'm going to quickly mention those differences perhaps to give an idea of what might be a role of a psychiatrist, psychologist, or any mental health professional, and which is the second subject. And lately is about the barriers and stigmas, which I think play a significant role specifically in this particular type of work. Next slide, please. What the first thing is question that arises is that is there any difference amongst transgender and gender variant individuals versus general population? There is no clear data saying that, well, look, it is established exactly how different it is. We already know that the needs of minorities in terms of the mental health changes, and one of them is because of being the stress of being minority. There are certain differences in terms of the type of stresses imposed on groups of individuals, LGBT group of people, and in particular amongst transgender and gender variant people, is that increases certain diagnoses. There's some sort of preliminary data coming out. One of them was that amongst the patients that Northwell put together data looking at what are the possible differences. This is just a cross-sectional look at the number of like around a few hundred people that I have visited and interviewed. Of course, it's biased because it's not the general population, it's the ones who've come to a center. But overall, looking at it and comparing the data out there, it was very interesting. Certain diagnoses were much higher. Depression and anxiety and things that related mainly to stress, the diagnosis around 50 to 60% of people were showing some form of symptoms related to these conditions. But certain things that are primarily, we think, possibly biological ones, such as schizophrenia, such as ADHD, such as bipolar disorder, they didn't seem to differ much from the general population. Again, this is not a comparison data and sampling. And when I checked the overall data coming from other places, that seemed to repeat itself as well. But the message there is that there are certain things that seem to be much higher amounts per certain group of people, in particular transgender and gender non-conforming people, most likely related to the stress. It's nothing inherently related to gender development, and there are some data supporting that. There was a huge epidemiological study in Europe that looked at LGBTQ youth as part of a study of the youth, a study across the whole, like I think 16 or 13 nations and Europe several years ago they did that, and they looked at, well, there is a clear difference in terms of depression, anxiety, and mental health diagnosis amongst LGBTQ youth versus general population. And when they corrected the factors of stress, which would be the home environment and the school environment, the risk actually dropped, somehow equalized. Amongst transgender individuals, we're not quite sure yet. It's been overarchingly amongst LGBTQ population, that seems to be the case. So primarily a lot of these ones are driven by the stress. I'm saddened to say that as the second part is that the risk of trauma is much higher, and that is because of various reasons that many people might have talked already here, and many people might also be aware of it. They're very youth. New York City is known to have the highest number of homeless youth or LGBTQ youth. Kids are kicked out of home when they come out. When people are gender variant and transgender, they often also lose their status not only at home. The school status can change. The future of work can be affected. There's high risk of sexual trauma, sadly, in the society. So these are actually related significantly on the social impact of discrimination, the impact of social discrimination on the individuals. And we need to know them, but we need to address them. One thing is at the social level to address them, advocacy, but the other thing is that it's unfortunate they happen and sadly they happen, but they also have significant impact on someone's mental health. That's another difference that bring a very special need for mental health care of a group of people that we're working with and we're talking today. Another matter is that separate to the problems that a person may have in regards to their mental health, there are some roles for mental health in the process of working with transgender individuals. And one of them is that a person may want to explore, as many other important decisions in life, there are elements of thinking about a thought process, family dynamic, changes in someone's life, different stresses come into that based on which age you're doing that. These elements bring up the role of a mental health worker, which in the next slide I'll talk more about it, is about the whole process of transitioning may actually need someone to be able to work with in a neutral way, which will be a therapy. It's not required, but at times people benefit from that. Of course, in the matter, as I mentioned, family itself does come with its own changes when someone is transitioning, either as a kid, young adult, or older people when they have formed their own families. When someone comes out and transition from one gender to another gender or is exploring their gender, it comes with the impact in the dynamic of the family. And that brings up a special need of family work in different form. If the stress is increased to the point that the family is having some struggle, that brings up a very special need for mental health intervention for someone who is in need of that. There are some differences also in certain diagnoses outside of the ones that I mentioned that I don't have in the slide, such as we suspect the eating disorder, for example, is much higher. The data is just forming. There's some reports of differences, and the idea is, well, we're talking about the shape of the body. We're talking about something very important that happens during adolescence, and that is puberty, the beginning of major changes in the body, and often starving and anorexia, especially at a young age, is a way to suppress puberty, or is a way to impact the body. That's another thing that can be higher. It's generally not a common condition in youth, but it's in disorder eating is actually way more common than having an eating disorder. These are things to think about them, and often there are matters that need a mental health evaluation to know the depth of it and the type of intervention. The last one is what sort of an overlap and transition from the general need of mental health and also the intervention is that understanding of a gender and gender development in a young person is part of understanding the identity and formation of that. They're intertwined, like inseparable. And because of that, actually, it's quite a natural process. The only difference is that some people don't have much idea about it, and it requires a special understanding of a gender development. Youth are very much now there's an increasing number of youth coming out these days in terms of questioning the gender, exploring the genders, and that brings a very special need for someone who can explore it or can actually see that if the path of an individual is going and needs any question, help the family work with that young person, and that becomes like the role of someone who is experienced in working with youth, has an understanding of a child development, adolescent development, and also is experienced and knows the gender development and can cover that bridge. It doesn't mean that each individual who is transitioning or who is exploring the gender needs mental health care, but it means that at times or pretty often they need to have some sort of contact or consultation. Can I have the next slide, please? Bridging to this one, which I've already started talking about, is that the whole idea of my presentation today was that I'd like to a little bit clarify the role of overarchingly like mental health professionals, what they can do. One of the main things we're thinking about going to see a therapist, a psychiatrist, a counselor in different roles. People can be a variety of roles across the disciplines as mental health professionals, is to provide care for a primary mental health condition. Kids, adults can have us. What's it like around 50-60% of people during the who identify as transgender, gender non-conforming, I'm saying this in bracket based on preliminary data that I've actually so far found, at least experience to a degree of depression, anxiety. There's much higher risk of suicidal thoughts as well. Perhaps substance use actually is also seems like to be slightly higher. So all these different conditions, they need their own primary psychiatric care. Definitely the mental health care needs to be specialized for, you don't need to do anything except that people needed to know it from the beginning how to be neutral and work with people who are gender variant. Unfortunately, that wasn't enough training in the past, but generally it's about being able to care for an individual their primary need. If they have depression, to treat the depression. If they have anxiety, to treat the anxiety. And also if there is a trauma, to help people to recover from trauma, recover the leftover of the trauma if there is a PTSD. And all the other ones. That's one, I think, obvious reason that one may see it, but that's not the only reason. One of the other reasons is that the role of a mental health professional, like many other fields of medicine, sometimes is communication and being a liaison between different in a multidisciplinary team to increase the outcome, to have a better outcome. It has started many years ago. Many people in different specialties know about it. When psychiatrists entered the team of transplant team that requires different disciplines to work together, it improved the outcome. The transplants, those people started having better outcome. So that from that angle, at times having a mental health professional within the team can help improve communication and can help improve the outcome and medical interventions. Is it surgery? Is it like hormonal treatment, or even other other medical cares? It doesn't definitely stop there, and one of the matters that come up there is that, okay, well, why we talk about even mental health care so much? Because I think there is a history of controversial presence of mental health professional in the field. If we go back to it, can you move to the next slide, please? I'd like to bridge a little bit to think about what are the barriers and the stigmas, and the reason I put this one here, I want to go back a little to history of it. What was the role of psychiatrists and psychologists in the past? It is unfortunate that we have to own it up that many years ago it started with pathologizing sexual orientation and gender identity. That started with diagnosing something that years ago, if someone was gay, had a diagnosis in DSM. It started with diagnosing as gender identity disorder as a condition of mental health condition, rather than understanding of it and having a better use of mental health professionals to help people and understanding gender development. Sadly, it became a sore at the side of many people, and rightfully so. Like they're angry for it, and that creates a controversial problem that exists till today. We know that overall, having a mental health need, it is a stigma in the society, and that's already a barrier to have access to mental health needs. Someone who needs to go to a psychiatrist, who needs to go to a psychologist, usually shies away because there is a stigma in the society. The language is used: are you crazy? Can't you do it by your own? Why don't you toughen up and do it? And terms such as shrink. These are things historically, when you hear about it, there is a significant stigma associated, even amongst ourselves. Think about, like, I'm guessing many people who are listening to this presentation, they are medical professionals or within the medical profession. Think about and remember the days that you were applying for your residency, or thinking about which field of medicine you're going through when you were doing medical rotations. I do remember myself, I thought I would never be a psychiatrist till I did psychiatry. It is stigmatized to be a psychiatrist. It's stigmatized to work in mental health professional. When we do rotations, like when someone is misbehaving on the floor, they say, call the psychiatrist, I can't deal with this one. The behavioral issues are highly stigmatized across the medical fields. That is, the stigma is a huge barrier to access to care, something that is so prevalent. Like 30 to 40% of people, across their life, they have a mental health condition. And the stigma becomes a huge barrier for it. Not only mental health is a stigma, we also have a stigma, unfortunately, around gender development and, well, generally around the LGBTQ community, and certainly even within LGBTQ community, against variants of gender development. Anything but cisgender development is considered off. And that has created a long-term stigma against someone who is gender variant. We have now a second stigma that is putting a label on someone, and it's unfortunate because the origin of the stigma is coming from the mental health professional in the past. Intertwine the stigmas together are making a very special need and access for a special group of people very hard. You have generally people shying away when they have depression, and the person who has to come and seek help historically has heard that, well, this group is going to hurt me. It makes it very complicated. And the only way to address it is we have to be honest, we have to be open about the history behind it and understand it. If you look at even WPATH changing its language and insisting on it, if someone has attended, WPATH is World Professional Association of Transgender Health, it really talks about that it still insists, or even the guidelines insist that, well, yes, mental health intervention is needed, but not making it as if it used to be in the past. Have you had enough therapy to transition? Of course, person doesn't need to have therapy to transition. It's their own journey. It's not for but if they have a mental health need that they need to seek care, it is a shame that because of the history, that person is not receiving their care because there are actually stigma barriers. How are we going to overcome this one? Education, education, education. Information, information. Educating ourselves, educating the community, and helping the system to move on. There is a shortage of number of people who actually can provide mental health care to LGBTQ youth, in particular to transgender youth and gender variant youth and adults. Often one of the biggest struggles that I have is that who am I going to refer the patients that I do consults for, and how are we going to have it? Hopefully it shouldn't be like that. Hopefully we shouldn't have this problem in future. Every mental health professional should actually be trained enough to do that. I agree. There are some people that I'd rather not see as certain patients. If someone has such a big issue still around gender, they shouldn't. But that doesn't mean, but I think there is still a ton of people out there that they can actually be trained, they're trans-friendly, and they can learn how to work with the community. I know there is shortage for a mental health professional to begin with, but the whole idea is that how to bring many of the people out there who are actually working in the field of psychiatry and mental health to be able to work with individuals who are in need of mental health care within the transgender and gender variant community. At this point, I want to stop, and if there is any question, I'll answer it.
Thank you, Shervin. I have couple of questions. One has to do with consenting. So there's a controversial issue whether even for hormonal therapy, transgender adults, children perhaps is a separate, or definitely is another issue, but transgender adults need to sign a consent form. My position on this is that, we prescribe as internists all kinds of medications without ever asking people for consent. Of course, we explain the side effects and so on, but then we just prescribe it if the patient is agreeable to that treatment. From your point of view, what's your position on the consent for non-surgical services in transgender adults?
Thank you for asking the question. I think that's more of a legal matter rather than a psychiatric matter. My idea of consent is like any other matter in medicine, as you said. The more complex the decision making is, I think the more complex maybe the conversation need to be around that matter. It is similar to even the question of consent and competency in many different situations that sometimes psychiatrists are called in to help. I think the same thing applies here too. Should it be signed? I don't know. I really don't have a clear answer. I don't see myself at a position to make that comment or not. I think it's really based on individuals. I know people even in the field of psychiatry, when they start an antipsychotic or antidepressant, they ask parents to sign a consent, or they ask people to sign a consent. I don't think there is any blank recommendation that you have to do that, but I think it is really the relationship between the physician and the patient. And I emphasize on that because I think that relationship by itself is very important. An individual is coming to us asking for help and developing a matter of trust. Is that signature and that reading of a paper going to help develop that trust and relationship, or is it going to be a barrier? I think it also depends on how it is given to the person, how it's communicated, and it even legally, I think it would be helpful. We know that the number of lawsuits drop when there is a better relationship, because there's a better communication, because the patient knows actually what they're receiving. That's as far as my thoughts go from this angle. I'm really thinking about the relationship of a physician, a provider with an individual, a patient who is coming to us. Whatever communication happens with them, both sides should be comfortable. I don't think a physician should also feel really uncomfortable feeling that they haven't had the consent established and when they're working with someone else. But I agree, it should not be much different. Part of it perhaps is because fear of unknown often makes us uncomfortable. I've been thinking about myself. I remember the first time I referred someone to start a hormonal treatment, I went so many times back and forth. Now, so it's not an unknown matter for me. It's much faster for me to make that decision and communicate. I think part of it is maybe fear of unknownness, of lack of partly it might be that one.
Well, thank you. And I guess I should clarify, my question was specifically about written signed consent.
Signed consent.
Right.
Yeah.
Of course, we always obtain consent from the patient.
But did I answer your question or not?
Sort of. I think you confirmed that it's a controversial issue.
It is a controversial.
I don't think there's absolute legal requirement for that. Mm-hmm. Some programs recommend it, others don't, and that's where it kind of sits at the moment. Another question I had, the International Classification of Diseases number, I think it's 11, that will take place, I think, in 2021, moving the transgender issues from mental health chapter to sexual health, and changing the term from gender dysphoria to gender incongruence. So from the psychiatrist's perspective, what do you think that will accomplish, if anything?
I think it's again another matter that is controversial. Not controversial in terms of gender, the moving the diagnosis is. Well, I have an issue, or many people don't have an issue with that. Is actually about the consequences of it in terms of access to care. I think most people agree that gender dysphoria by itself is not necessarily a psychiatric diagnosis, but that's exactly, I think it taps into what I was talking earlier as well. There is an inherent stigma with having a mental health diagnosis, with having a mental health condition. And that by itself, I think it speaks by itself. Having anything related to mental health means a stigma, and and I accept it. I think that's the thing, and that's why people say why should this be put in the category of mental health, and let's move it to the medical. One may argue that, well, look, if you really take away the stigma, then what is the difference between mental health part of the diagnosis versus medical part? At the same time, I think the reality is that the stigma exists out there. The community has been hurt by the stigma, and I think it actually does help in that aspect. The counter argument is that, unfortunately, at this point in the US, access to care is very much regulated by insurances and the code of diagnosis. In changing the code of diagnosis has feared many people that will give permission to perhaps certain insurers to deny care. As it moves with the destigmatizing, which I think is a good idea, but that's not the only way to destigmatize, is that it's going to move towards that saying that, well, if it's not a condition, then why should we treat it? Often, most of the procedures, and I think that has something to do with the nature of it, is that when you want to apply for the medical necessity of the procedure, is about the mental health aspect of stress on individuals. But when we're talking about facial feminization, it's about how much an individual is suffering from having certain bone features that are distressing for them. And this surgery is medically indicated because it has a significant negative impact on their mental health. I am worried that these changes can jeopardize the future of insurance coverage for some of the procedure. That's one of the worries from the event.
Thank you, Shervin.